Oke, selamat siang semuanya. Good afternoon, everyone. Thank you for joining us today. My name is Sandy Yulianto, and I am the Referral Partner Manager for Indonesia at My One Health. So before we begin, allow me to give the brief introduction about My One Health. So My One Health, we are a global health facilitator platform. We're dedicated to connecting international patients with over 350 plus hospitals and clinic over 21 countries. Through our network of trusted medical partners, we help facilitate international medical checkup, second opinion, personalized health package, and specialist consultations. And all without any additional fee. Our goals is to make quality global healthcare more accessible for international patients, regardless their health concern. And today we are proud to collaborate with Sunway Medical Centre, one of our leading private hospital in Malaysia, located in Bandar Sunway, Selangor. Sunway Medical Centre is an international accredited by GCI and ACHS and recognized among the top 250 hospitals globally, with over 28 centers of excellence and support for more than 113,000 international patients from 170 plus countries. They truly set the benchmark for world-class healthcare in the region. And it's an honor to welcome our distinguished speaker from Sunway Medical Center today. We have Mr. Lim Wei, the Manager of International Business Development, who will provide an overview of Sunway's international patient service and how Indonesian patients can benefit. And later on, we will have Dr. So Jin Kim, the consultant in general surgery, upper gastrointestinal surgery, and weight loss surgery, who will be sharing medical insight and procedure available at Sunway. Yeah, without further ado, let's begin the session, and I'll now hand it over to Mr. Lim Wei to start the presentations. Thank you.
Hi. Thank you very much, Andy. Let me just share my screen. Andy, could you give me a thumbs up if the screen is up for everyone? The screen up?
Yes, we can see.
Okay, great. Good morning or good afternoon if you're from Malaysia. So my name is Wei. I'm actually in the international business development. So basically, we promote medical tourism for patients or anyone from around the globe. Would like to see quality healthcare in Sunway Medical Centre, Malaysia. So here, what you see is actually a bird's eye view of our medical center, right? Where it actually sits in a township, right? This is a township. We call it a Sunway, Bandar Sunway. So in English, what it means it's Sunway Town. All right. So Sunway Medical Center, it's part of Sunway Group, right? So Sunway Group is actually a conglomerate in Malaysia itself, right? So they actually have a variety of businesses itself, right? So one of the things that they do very well is actually building townships. So what you see here, let me just put up a pointer, right? What you see here is this is our medical center, all right? Our A, B, C, D, E, F, right? And you can actually see that the theme park is just next to it. We have our hotels. We've got 3 hotels within the vicinity, and we have our Sunway Pyramid Mall all over here, which is all within walking distance, right? And then next to Tower D, we have our universities. We have Sunway University, Monash University, together with Sunway International School, and a few more buildings, which is part of Sunway ecosystem itself, right? So moving on, just give me a moment. Next slide. Yeah, so just as explained earlier, Sunway Medical Centre is part of the Sunway Group, which is a conglomerate. We have 13 business units, right? These are the different business units that's part of the group, right? We have the B2B, basically to the business side, which is construction, right? What else? We have also, on the other hand, the consumer side of business, right? Medical center, healthcare is one of it. Malls, education, right? Leisure, hospitality, etc. Right? We have 13 business division in over 50 locations worldwide, and we are 16,000 employees strong, right? So this is just a glimpse of the group itself, right? So zooming in into healthcare, right? Healthcare group, we actually have what you see just now in the first slide. It's our flagship hospital, Sunway Medical Centre, Sunway City. Apart from that, we have another 4 more hospitals in Malaysia, right? 2 more in Kuala Lumpur or Selangor, basically in the Klang Valley region. One in Penang, up north. The other in Perak, Ipoh. So this is the most recent one that we just opened in April, right? This one we opened in Ipoh because Ipoh is actually a birth town of our founder of Sunway Group. We do have a few more hospitals coming up within the next 5 years. So these are some of the hospitals that we've lined up, and it's actually under construction. Other than the quaternary or tertiary hospitals, we also have the ACCs, ambulatory care centers and fertility centers, right? Here in Damansara, Selangor, Singapore, Kuching, Sarawak, and also some of the supportive or complementary services like traditional Chinese medicine, right? Home healthcare, telecommand center, and Sunway Sanctuary. So Sunway Sanctuary, it's a senior living senior living accommodation, which is just right above the hospital itself, right? So just to sum things up, next slide, right? So this is just a night view, right? Just to sum things up, we have 6 towers itself. Sunway Sanctuary, which is the senior living facility, it's above Tower D, right? From 15th floor onwards up to 30th floor. Whereas at the bottom, it's our hospital. So different consultation clinics, right? In the ground floor up to 12th floor itself. So here, what we have 810 licensed bed as of now, right? But the built up capacity is 1,100 beds, right? This is after opening of Tower F. Right now, it's already built. It's just that we are still recruiting nurses, right? So we're looking at opening up Tower F next year. So Tower F will be a primarily children's tower. And why it's dedicated for children's tower? It's because the rooms for children wards, it overlooks the theme park, so it's good for them for recovery. All right. So just a bit of history itself. We started off with Tower B, in fact, rather than Tower A, in 1999. All right, so this was 26 years ago. Last year we just celebrated 25th year anniversary, right? Tower B, we started with Tower B before we expand to Tower A in 2006, right? So that's actually a 7 years gap itself, right? Whereas 2016, 10 years later, only we open up Tower C, where it's a dedicated cancer tower, right? So cancer, hematology, etc. Will be in Tower C. 2016 onwards, we open Tower D, followed by E and F. All right, next slide. So we've expanded very fast in the recent years, right? This actually been reflected in some of the recognition that we get the past couple of years. Just to summarize a couple, right? We were ranked one of the 250 world's best hospital, right, for 2 consecutive years itself. 2025, we were ranked 193, but in Malaysia, we're the ranked number 1 hospital. We also are triple accreditation. So we're JCI, ECHS from the Australia, MSQH is from Malaysia. Next slide. So these are just to promote some of the key specialties that we are highly ranked. Pediatrics were number one, right? Of course, some of the others like oncology, which is reflected with we have our Tower C, right? Cardiology, cardiac surgery, neurosurgery, orthopedics itself. So just a snapshot of Sunway Medical Centre. We have 28 centers of excellence, more than 60 medical specialties. As mentioned earlier, we have 810 licensed beds as of now, right? With the build-up capacity of 1,100 beds, more than 4,000 healthcare professionals, 20 operating theatres, all right, and some of the key figures over here as well. Moving forward, so our hospital pride ourselves in investing in cutting edge technology, right? So these are some of the devices or equipments that we have, right? Our hospital has been, with our chairman has been actually, constantly asking us, what kind of medical devices or the latest medical devices that the hospital is lacking. In a way, it's asking us to keep upgrading ourselves, right, to make ourselves more relevant, right? So these are just some of the latest equipments, and we're continuously investing in more technology down the road. So just a brief snapshot, because I'm from international business development, right? So these are some of the services for international patients. So we have a dedicated international patient center where we handle appointment booking, inquiries, second medical opinions, right? Visa extension, transportation, accommodation arrangement as well. So we have a dedicated team. We have people with people speaking with different languages: Indonesian, Cambodian, right? Chinese, because it's one of the common language that we speak in Malaysia, and also other languages that we support. We have an international patient ward in NF. On this third image, this is our lounge, right? So it's in an open space in the middle of the hospital, right at Tower C. So it serves as a central point or a focal point for patients, international patients primarily, to walk in case if they need any help. So we have also patient care coordinators. So these are the team that would actually support, especially first-time patient, right, to bring them to the clinics, right, to help them with the pre-registration when they are in the hospital. Because we realize also that the hospital is sometimes too big. We need the international patient requires some assistance on ground. For picked up, and then of course we have cashless facilities with a number of insurance company. So last slide for me, Sunway Sanctuary. So this is the senior living, right? Of course, it also acts as a hotel for international patient as well. We have 2 floors dedicated for international patient. So this is above the hospital. It operates under a different license, although it's managed by the hospital team as well. So you can see that some of the facilities overlooking the great view of Sunway City, and this is the room how it looks like. All right. That's all from me. Shandy, do we actually have Q&A now or like later after together with the doctor's presentation?
Is doctor ready now?
Yes, the doctor is here.
Yeah. Okay, I think we can hand it over to Dr. Su, and
Okay,
we will ask the questions later on the Q&A session. So I will welcome everyone. If you want, feel free to write questions if you have any questions, and we will address it later on the Q&A sessions.
okay. Then just give me a minute. I'll switch it over to Dr. So.
Sure.
present using the alphabet. You can see me, right? Yeah. I
Yes,
just
Doctor.
stop sharing your one. Hi, hi. Good afternoon, Shandy, right? Hi, nice to meet you guys.
Yeah, good afternoon, Doctor.
And then without further ado, I think I will just introduce myself. Okay, my name is Dr.
Sure.
Su Jin Kim. I'm Malaysian. I'm not Korean. That's why I get a lot of things think that people think that I'm Korean because of my name. I'm a general surgeon and also an upper gastrointestinal surgeon, and also I do bariatric and metabolic surgeries. Yeah. So how to get just click on it. Yeah. Okay. I have no disclosures. Just that I work for Sunway Medical Centre. This is where I work. You can see this is our tower A to tower F, all right? And okay, I'm going to talk briefly on upper and lower GI tract cancers. What should we really be wary of? I think what are the concerns? Yeah, and then basically upper GI and lower GI cancers. Lower GI mainly is the what we call as the colorectal cancers. Yeah, upper GI mainly involve the esophagus and the stomach. Also, I'll share with you guys a little bit on the subspecialty that I do, really the upper GI subspecialty realms, which includes anti-reflux surgeries, functional disorders, and also obesity-related surgeries. Mm. So, for those who don't know, common role of general surgeon, yeah, these are I want to share with all the key industry players that we do, like abdominal surgeries, includes esophagus, stomach, small bowel, colon, liver, and of course gallbladder and the biliary ducts. Um, and of course, all lumps and bumps, skins and soft tissue surgeries also we do. Some general surgeons also do simple breast excision, breast lump excisions, and thyroid cancers, thyroid diseases, and also trauma. And not forgetting, we also do scope endoscopy, the upper scope (OGDS) and colonoscopy. Right. With that, I share a little bit about basically what do we mean by upper GI symptoms and lower GI symptoms. I can see on the left side of the monitor here, the heartburn, which is the pain, the how you say the burning sensation, usually at the upper abdomen, central, is usually that's because of all this reflux, yeah. And then belching, regurgitation, and epigastric pain. Pain itself is also a symptom, yeah. That's all for upper GI symptoms, and also unexplained weight loss. Now, for lower GI, it's mainly the bowel related, large bowel related, yeah, the colon and the rectum. Sorry, how do I go back? Yes. So mainly like unexplained diarrhea, bloody diarrhea, or increased flatulence, urgency to pass motion, and also lower abdominal pain. Yeah. So upper GI you have upper abdominal pain, and lower GI you have lower abdominal pain. Because these are just some of the diseases that they listed up here. That's not so important. Now, okay, I will talk about the warning symptoms here of upper GI cancers. So, like I said again, unintentional weight loss is very important. Loss of appetite, um, and then upper abdominal pain, dysphagia is difficulty to swallow. Of course, solid food. Then some patients might say difficulty to swallow even fluids. Yeah. Now, early satiety, after a few spoonful, the patient will feel full. Yeah, these are all upper GI symptoms. Some may present with anemia, and some may also have vomiting. Yeah, anemia simply means lower hemoglobin levels. Yeah, on the routine health checkup. And if you see on the right side of the screen, right, this is an endoscopy picture of a growth growing at the lower esophagus. Now, this is abnormal, yeah, and it has a little bit of bleeding around here. And the same goes here. It is an earlier picture, but almost half circumferential of the lower esophagus. Now, a bit on esophageal cancer. Just bear with me. I'll just share a little bit. So, earlier detection is good. So, it's like if you can detect it in this, it's called the carcinoma in situ, whereby it is just a small mucosal lesion here. So, as it goes deeper, the T1 stands for tumor, yeah, the tumor invasion across all four layers of the esophagus. Now, this is the innermost, the mucosa level, and this is the muscular level, and this is going up to the serosa and, of course, surrounding organs. So we can see here T2 is going deeper, T3 much deeper, T4A and T4B. The only difference between T4A and B is that it involves maybe the major vessels like the aorta. Yeah, and of course, if it spread, it may also spread to the surrounding lymph nodes, like you see the surrounding fat over here. That is already N1, N3, N3, depending on the number of lymph node involvement. Yeah, and then of course, this if it spread to the liver or the lungs, it is considered stage 4 disease. It is metastatic disease. And another thing I would like to share is about chronic reflux. Yeah, chronic reflux is a risk factors for low development of lower esophageal tumor like this. Why is it so? Because chronic reflux will predispose to hiatal hernia. Basically, what is hiatal hernia? The rooftop of the stomach actually goes above the diaphragm level here, especially like you see here, and then it is diagnosed only by endoscopy, which I do a lot, to see whether there is this looseness. Usually this area shouldn't be there. It should be well held tightly without any looseness over here. Like this mucosa should be at this level. You shouldn't have a defect over here. Now this is called the hiatal hernia, and let's say it doubles the scope diameter over here is already grade 4, and this hiatal hernia will predispose to lower esophageal, what we say as esophagitis. If you get circumferential like that, that's where you get the burning sensation at the mid chest level and the upper abdomen over here. And this tends to be, it can cause to the long term can cause cancer change. So this picture is basically to say again development of tumor around this area. We call it the junctional tumors, and these are all adenocarcinomas. So on your right, as it's a bit busy, it's basically about the factors affecting stomach cancer. So you should also know that always I would say you think of the Japanese and think of the Korean food. Yeah. So if the food that we take is very high char, very high in sodium, in salt level, and then all this raw fish, all this is actually we say carcinogens to develop junctional tumors or even stomach cancers. Yeah. And of course, other things like the bacteria, Helicobacter pylori is a known bacteria that colonizes the stomach. That is also can be diagnosed during endoscopy, and that poses a risk factor of up to the 70% of development tumor. And these are all the risk factors that can cause mucosal irritation and slowly develop invasive tumor. Now, moving away from tumor again, let you guys take a breather a bit. Now we go back to this our endoscopy suite in ground floor in Tower C. So you can see that this is where we register our patients, and that's where you go in. And inside, for we have a VIP room for our VIP guests patients. So it's a nice room attached to the bathroom on the side over here, so that people can when you do a scope, you can rest there, and then you can, even when we do bowel preparation for colonoscopy, there's an attached bathroom at the side. There's also a TV here, and this is a general area for the other patients. Yeah. And this is the same picture where you got the dietary clinics that we have, and the waiting bay, general waiting bay, and some this area where we wait for registration. Now the things that I do, okay, I do scope. So a little bit of introduction to about OGDS. OGDS is the scope whereby we scope the esophagus and the stomach. So this is basically to how you say inserted per oral from the oral cavity under sedation. Yeah, we give sedation to the throat and also intravenous sedation. So the patient will be slightly in a sedated state like that, and the operator, the surgeon, and or the gastroenterologist will be here to do the scope. But there's nothing much to be afraid about, because this scope diameter is actually 9.8 millimeters. I repeat, it's only 9.8 millimeters. It is not a very big, it's hardly even 1 centimeter. Yeah. So it is quite safe to do when you tell your clients. Yeah. And on your right, here of the screen, you will see a tumor growing here, and I also insert a stent, nitinol stent through to bypass the tumor, so that at least the patient can have some quality of life. Now, okay, moving on to that, this is a bit of a gory picture for you guys to see. Basically, this is a specimen of the stomach. The entire stomach has been removed, and then a small area here. I want you guys to focus here. This area can be diagnosed during endoscopy, and only on biopsy, this small area is actually cancerous. compared to the normal area over here. Yeah, so the endoscopist must be well enough to see it's just an ulcer and with the raised edges. Yeah, but this is a malignant cancer. Yeah, of the stomach. Now, just a quick one about management of esophagus and sorry, about esophageal and gastric cancer. Basically, it's depending on the stage. So if we detect it early by regular screening, regular endoscopy, we can diagnose it with stage 1 and stage 2, then we aim for curative. We can at least aim to cure the disease, mainly surgery. But once the patient get to stage 3, sadly to say, a lot of upper GI cancers are diagnosed at stage 3, yeah, even in Malaysia. So this is at a level of potentially curable, whereby we need to give the patient perioperative chemotherapy, followed by surgery and, of course, post-operative chemotherapy. As for the stage 4 is basically the disease has spread outside the upper GI tract. It has gone to the lung or liver or even bones. So this is they're spread elsewhere. So there's no longer a role of surgery. Yeah. Mainly we can do palliative stenting or palliative chemo or radiotherapy, but no longer cure. Yeah. Now, this is a bit of surgery for the esophageal cancer. So you can see the entire stomach here, and the cancer is around this junctional area on the lower esophagus. So what do? We upper GI surgeons like myself do is that we create it like a tube. We resect this part of the tumor, all right, with the thoracic duct and the surrounding lymph nodes, and we preserve this part of the stomach to create a new esophageal conduit to be the new esophagus, and we pull it up to the neck. Yeah, this is the resected specimen. And this surgery can be done via open surgery or minimally invasive, that means laparoscopic and thoracoscopic, plus or even robot assisted. Yeah. So the minimally invasive, we call it minimally invasive esophagectomy, MIE. Yeah. But this is just to share a little bit about robot assisted. As you can see here, this is a Da Vinci Xi robot. These are three Da Vinci arms here. The fourth one we actually not taken here, but we utilize 4 ports and then with the assistant port or the assistant here. But these are the 4 trocars for the robotic arms. Yeah, so it's robot arm 1, 2, 3, and 4. Okay, and this is the thorax of the patient. Yeah, patient is lying semi-prone. Now, this is also a picture of the robotic view, whereby we can, after we resected the specimen, this is a new esophagus that being created using the stomach, and I also reconnect it, we anastomose it to this part, which is the lower esophagus, and we can check the perfusion of this area that we stitch the anastomotic area to see green, meaning that the perfusion is good. So you can see all around here is all green. Yeah, so green means which is good for the perfusion. It reduces the risk of leak. Yeah. We do this. It's called basically this RAMI, robot assisted minimally invasive esophagectomy with intraoperative ICG to assess the anastomosis. Okay, moving on away from surgery, this is the fluoroscopy suit, which just now I've shared with you guys. I also do a lot of advanced endoscopic procedures, so whereby we do in this endoscopy suit. Now, for example, this is actually a stent across the esophageal tumor. So as you can see, contrast is held up before there's no contrast, and I mean there's a little bit of contrast here that doesn't go through. So after we stent the patient, then you can see contrast traveling all the way down. There's dark, the contrast is basically a dark shadow here and moving on into the stomach. Yeah. So I also insert nasogastric tubes, nasoenteric tubes to go across tumors. I can maybe can place in the stomach or it can be placed in the small intestines to build up the patient's nutrition while going for chemotherapy. You know, these are all to enhance the nutrition of the patient and make sure that the patient is fit enough for surgery. Now, with that, I move away because I only got 15 to 20 minutes, so I move a little bit faster. So I'm going down to the lower gastrointestinal tract. Lower gastrointestinal tract basically involves the rectum, the place we store feces before it's been expelled out, and then the colon. The colon is basically the light greenish, the bluish color and all the way up to the purple color here. These are all the right-sided colon, and this is called the transverse colon, and this is the left side part of the colon, and this part before the rectum is called the sigmoid colon. So these are just the part of it. And as we all know, the appendix is an appendage here, whereby near the small bowel, where the junction between the small bowel enters the large bowel here. And most of these tumors are adenocarcinomas, colon and rectal cancers are adenocarcinoma. And then the good thing is they have a screening test. We can test the stool for occult blood, and then the diagnostic test will be a colonoscopy, yeah, and a biopsy. Yeah. Now, as you can see here, just like just now, how I share about upper endoscopy. Now, this is for the lower scope. You call it colonoscopy. So the patient will be lying, not facing the operator or the surgeon. He will be facing towards the monitor on the left-sided position, left lateral position, and the scope will go through here. Yeah, right, the anus, and then all the way down from the rectum, all the way down into the small bowel over here. So as you can see, this is the procedure it goes. And then if we find any small polyps, any small mucosal growth here on your lower right side of the screen, we will try to excise it endoscopically. That is very common to see all these small polyps. Some may be malignant, some may be benign. Yeah? And on the top lower left corner over here, this is another picture showing a colon cancer intraluminal. That means from the scope, you can actually see a mass here. Yeah, but this is exactly about T3 already, like it's almost obstructing. Yeah, so we'll take biopsy of this lesion and we do the necessary staging. Again, colon cancer is not as scary as upper GI cancer, okay, but it's more common. Yeah, in Malaysia, we get roughly about 3,500 new to 800 new cases per year. Yeah, so again, management is always stage dependent. Stage one, stage two, we aim for cure, that is upfront surgery. Stage three, we aim for potentially curable. We go for perioperative chemo and or chemoradiotherapy. It is for rectal cancers followed by surgery. And of course, after surgery, we may give adjuvant chemotherapy. Now, as for stage four, mainly it is not entirely no surgery. Sometimes we do palliative surgery for colon or rectal cancers. Also, we can stent the colon across colon or rectal tumors, and of course, palliative chemotherapy. Yeah, palliative oncological treatment. Okay. Now, again, this to share a little bit about colon, right-sided colon tumors. This is a picture of it. It's not very clear. It's a bit small. I can see here, this is the arrow here is pointing towards the growth in the right side colon here. So the patient have to undergo something like a right-sided colon resection, like a right hemicolectomy. And we try to anastomose down. On your lower left, of course, it shows the when the tumor is around here, we resect and we try our best. As surgeons, we try to join it back for the patient so that to ensure bowel continuity and the patient can pass motion. However, if there are some cases whereby the tumors are too enlarged and too stuck or too to the stage is already progressed to stage four, we do palliative resection with an end stoma. That means the patient, the part of the bowel will be taken out and brought out as a stoma outside here. Not a very insightful thing to have or see or to manage, but this is just to impress upon everyone that early screening is important so that early diagnosis and of course we can treat the cancer earlier. This is again going back to the OR. I showed this is our OR, the latest operating theatre that we have in Sunway Medical Centre. Yeah, it's located in Tower D. And this is our robotic system, the same Da Vinci Xi system. So as you can see, only the nurse and one assistant will be by the patient's bedside. This whereby the robot is being docked to the patient. Yeah. So then you can't see the operator because the surgeon is actually sitting on the console at the back over there and then operating. This is another view to see. See, the scrub nurse is always with the patient to ensure patient safety and to change the instruments. Yeah. Now, okay, I'm done with the upper and the what do you call it, the upper upper GI and lower GI cancers. Now I move on to other things that other services that surgical services that I also do is within the realm of upper GI surgery. I do anti-reflux surgery. A lot of people do not know, the general public do not know that actually very chronic reflux, refractory to medication, we can actually offer surgery because we can repair the shortened lower esophagus and also repair the hiatal hernia. These are all done by minimally invasive surgery, by keyhole surgery, either laparoscopic or even robotic. Yeah. This picture is to show that why people get reflux so much, because the gastric acid and contents actually reflux out to this physiological sphincter over the lower end here. So as it reflux, the esophagus shorten and it pulls a part of the stomach, the roof of the stomach up, which gets you the hiatal hernia. Yeah. So hiatal hernia surgery, you can do a 360 wrap after correcting, bringing down the lower esophagus, and then we repair the diaphragmatic opening, the hiatal opening over here. We will do a wrap. The wrapping mechanism of the proximal part of the stomach actually reduces the acid. That's why it's an anti-reflux surgery. We can do it via an anterior, we call it door fundoplication, 180 degrees, and a posterior, 270 degrees. In Europe, this is more widely practiced. That's why I went all the way to Germany for my fellowship. I do all these two, mainly doors. Doors is a lot practiced in Australia, and this anterior 180-degree wrap. It's just the folding of the stomach and putting a few stitches. This surgery does not involve any resection of any part of the stomach. Yeah, it's just to restore the normal anatomy. Yeah. And I also do gallbladder surgery. As you can see, it is laparoscopic or laparoscopy, mini laparoscopic cholecystectomy, removal of the gallbladder with stone inside, also with intraoperative ICG. So these are the intraoperative ICG. This is the gallbladder they are looking at on the far right, and then this is the ICG. Is basically the green dye that I told you. It's given intravenous so that you can see highly perfused area. So this is a common bile duct attached to the right and left hepatic ducts. It's a very important area, and this is a cystic duct. So it's actually clamped very far down over here. And the far right is my surgery, whereby I put two clips over here and remove the entire gallbladder. Okay. Now, lastly, I'll come to this part about bariatric intervention. What is bariatric surgery? For those who are not very familiar with that, bariatric intervention is whatever we bariatric um, procedures that we do for basically obese, the general obese patients. Yeah, so it can be non-operative by inserting an intragastric balloon, or operative like we have a restrictive component and malabsorptive component, or a combination of both. Yeah. So I do basically laparoscopic sleeve gastrectomy, laparoscopic gastric bypasses, and also laparoscopic sleeve plus procedure. That means a sleeve with an added proximal jejunal bypass component. Yeah. So intragastric balloon is purely restrictive, is to insert a balloon inside our stomach over here. Yeah. So it's a small capsule, it can be swallowed. Yeah. There's two types. One is the capsule where you swallow it, and then there's a device whereby we infuse the solution inside and inflate the balloon up. So take up space so that the patient cannot eat so much. Yeah. But the side effect of this balloon is basically vomiting. Yeah, initially the first few days, but we'll give a strong antiemetic medication to prevent vomiting. This the capsule and intragastric balloon is being swallowed. Yeah, so but you need a fluoroscopy suit. You do not need to insert via a scope. This is the same balloon that you see a small capsule pill over here where you need to swallow it down. Yeah, and this elliptical balloon. Yeah. Now, another one is inserted with a scope. So you can see here, there's a scope device over here. You need endoscopy to insert it. The balloon is deflated. Then once the device is put inside the stomach, then properly positioned, then we inflate it, yeah, using this area. This is called the Spark-3 balloon. But however, this type of balloon, you require endoscopy to insert and also to remove it. Yeah. This balloon can inflate all the way up to about 700 mils of solution. Yeah, so that to make sure that it really occupies a big space in the stomach, and you can put it for at least 1 year to achieve maximum weight loss. Now, a little bit on the bariatric surgery. Now, I'm going to move on to bariatric surgery. So the restrictive component is to basically make the stomach smaller into a sleeve component, or we can do it into a smaller pouch and do the row-wide gastric bypass. But ultimately, basically, we change the macronutrient preferences and we improve the glucose hemostasis. So we make sure that there's a sustained weight loss. Yeah. So with a very simple thing, basically we make the stomach smaller. The foregut trainer said that we bypass the proximal stomach and make sure that the the hormones from the proximal small bowel doesn't get secreted by excluding the food passage from the into the proximal stomach. And after you exclude the proximal small bowel, then we also follow the hindgut theory whereby we do a rapid early delivery of nutrients into the small bowel. After it's bypassed, we deliver in the small bowel to stimulate this hormonal release, GLP-1, to increase insulin secretion and ensure better glucose metabolism. So basically, we want the positive effect of bypassing the the proximal small bowel, and then the positive effect of early delivery into the distal small bowel. So this operation basically is about the bariatric surgery is done by surgery too. Yeah, so this is the standard bariatric port placement. Now this is the stomach that you can see here. This is basically the sleeve that I say. Yeah, we convert it. We staple off this part of the stomach because the main hormonal hunger hormone is very concentrated in the fundus of the stomach over here. So when we resect this portion away, then you will see that the patient's hunger drive also actually get reduced, significantly reduced. And this is the Roux-en-Y gastric bypass. It's very common in Europe. Basically, it makes the stomach, you fire across here and here, staple across the stomach here, leaving it to a small pouch. And plus that, you cut the small bowel over here, and then we bypass it. So this is a Roux-en-Y gastric bypass. But nowadays, we are moving a little bit away from this Roux-en-Y gastric bypass, at least for my practice, because I find that you cannot do endoscopic surveillance because if you see on the far right of the screen, the bypass stomach is just this small cavity here. Then when you put the endoscopy in, the scope in, it goes into the small bowel straight away. We cannot surveillance this part of the stomach. So let's say a patient develop any ulcers, any tumor around here, then we cannot actually go through it. Yeah. We cannot, there's no way you can go all the way down here and go back into the stomach. It's a very difficult and daunting procedure. So I move away to doing this laparoscopic gastric bypasses. But what do we do? That's why it comes the invent of this laparoscopic sleeve plus procedure, whereby if you can see here, this is the entire stomach. We sleeve the stomach over. I mean, make sure we remove it so it's small, and then we bypass it. So this is a proximal small bowel. We deliver it directly into the terminal ileum, which is the distal small bowel, bypassing this entire length of small bowel, at least about 180 to 200 centimeters. This is called the sleeve plus procedure, sleeve with the added bypass. So you want to know more, it's called single anastomosis, duodenal ileal bypass. The good thing is it's only involve one small bowel bypass. Yeah. The same thing, you can do proximal jejunal bypass, you can do a duodenal jejunal bypass. It's the same, but basically the principle is the same. Rapid delivery of nutrients into the distal small bowel, bypassing the proximal small bowel, and then added with the sleeve. Okay, again, this is the same picture. Now, this is the sleeve with a duodenal ileal bypass. And okay, lastly, I want to show about the effects of bariatric surgery. This picture is used by, of course, it's actually sent by my patient to me. She's she actually told me that she needs surgery, and then I did perform a surgery, and you can see the vast difference. Yeah, back in just in March 2025, and this is in May, and before this was back in last year December. This is how she looked like. And the transformation, this is how she looks like now. Just like 2 months ago, you can see that she has lost significant amount of weight. And this was before surgery, and now this is how she looks like after surgery. You can see the positive effect. And I also dare say that she only underwent a sleeve without a proximal by a small bowel bypass, and she's off her diabetic and hypertensive medication altogether. Now, this is another two more pictures that I want to share. Okay, this is a super obese Chinese male. Okay, which is he weighs about 168 kgs back in 2023, and he was having difficulty as he walked into my clinic. Also, he has difficulty in breathing. Yeah, so back in now in May, about 3 months ago, he lost all the way up to 118 kilograms. Yeah, so a good about 50 kilos he lost. Yeah, almost. So that's how he looks like. And on your far right over here, this lady, this is how she looked like. She was about 102 kilos. She lost about almost half of her weight. Now she's only 73 kilos. It's the same lady. Yeah, I can see the significance in the face. So with that, I thank you all for your patient listening. Yeah, I welcome all questions. Yeah, with any sort of my any part of my presentation, be it the cancer part or the bariatric part too.
Sure.
Okay.
Thank you, Dr. So Jin Kim. We have some questions. First, like, do you offer organ transplant case for international patients?
No, I do not do organ transplantation. Yeah, but because organ transplant is basically go on to the respective discipline. Like let's say liver transplant is done by the liver surgeons. Yeah,
Mhm.
because that's not my realm. My realm is actually the stomach and the upper esophagus, and I'm also a general surgeon. Yeah.
Yeah. And there's another one, like, what are some of lifestyle change one can make to reduce the chance of getting GI cancers?
Okay, lifestyle changes, of course, right from the diet. Diet is one of them that you have to modify your diet to like low salt, less oil, and then take less charred food like barbecue food. Yeah, those barbecue food. Yeah, and even try to not say avoid, try to eat less of all this uncooked food, like raw fish, like sushi, all those stuff. So
Mhm.
basically, these are the lifestyle modification we can take, and then of course undergo routine endoscopy, at least a diagnostic once in your lifetime to see that whether do you have reflux. If we treat the reflux, you can reduce the risk of getting cancer significantly. Yeah, and then we must also keep ourselves fit because obesity is a risk factor for to developing reflux because of the hiatal hernia. So if you prevent yourself to be obese, you take care of your diet and you exercise a lot, then that greatly reduces the risk of upper GI cancers. Yeah.
Sure. Thank you, doctor. And do we have a cure for chronic gastritis or GERD?
Yes. Of course. Good. Definitely. Good. It has to be because of something else like a hiatal hernia. Yeah. So if you do surgery, it's corrective surgery. Basically, you reduce the reflux, and it's very very how you say very nice surgery to perform, and the patient will get symptomatic relief. So if morning you do the surgery, you correct the anatomy, at night you will not have that burning sensation anymore. That is for the reflux part of the to cure it completely. And it doesn't prevent cancer, but it reduces the risk of developing lower esophageal junctional tumors. And of course, can you treat with medication? Medication can for those like very early lower esophageal reflux causing lower esophageal early esophagitis, then yes, you can give treat with medication, or even a small hiatal hernia. The hiatal hernia is divided into four: grade 1, 2, and 3 and 4. 3 and 4 usually require surgery, and 1 and 2 of the hiatal hernia, we usually start off the patient off with medication first. Refractory to medication, then only the patient will go for this anti-reflux surgery. Okay, so can it be treated? Yes, this condition can be treated
Sure.
both medically and surgically. Yeah.
Thank you, doctors. And there's another question. Does the consumption of wheat products increase the chance of GI disorder?
Sorry, the consumption of what products?
Wheat,
Uh,
wheat, the,
weight.
yeah,
You mean the consumption of weight products? That means weight loss products. You mean? Is
no,
it?
no, no, like, um, wheat, like the flour.
Oh, wheat. Okay, wheat. Okay, okay. No, basically consumption of any carbohydrate. Wheat products are basically your bread, all your pastries, those cakes and all the stuff. Of course, that worsens of course, that gives you a very high glycemic drive after we consume it. Basically these are all under the group of macronutrients called carbohydrates. So as you consume this, you will tend to, how do you say, gain weight, because and of course, your insulin will give you an insulin surge, so it make you feel good. Okay, how does this affect the reflux? If you already have how do you say, a hiatal hernia or already reflux, then yes, with the absorption of fluids and all, then you'll get a lot of bloatedness. You'll worsen the reflux. Okay, but to answer to the second part of the question, does this taking wheat products aggravate to cancer? No, it doesn't. It doesn't. But if you already have this hiatal hernia, some structural defect, and already very bad gut, I suggest you can reduce the intake of these carbohydrates and also wheat products like bread, pastries, all the things, so that you can reduce the bloatedness. Okay, yeah.
Yeah. Okay. I think that's all for the questions for Dr. So Jing Kim.
Okay,
I think we will another questions regarding the hospital services. May I
okay,
ask
sure,
you?
sure.
Yeah.
Yes. Administration. Yep.
Okay, thank you, Mr. Lee. We have a question like, is there any pickup service on Sunday from the airport?
So currently, we provide complimentary transfer, right? During weekdays, 7 a.m. to 9, right? Saturday half day itself. On Sunday, our drivers don't operate. But of course, Grab, AirAsia ride, it's easy to arrange nowadays as long as you have a mobile phone. Other than that, there's a lot of taxis that you can actually arrange at the counter when you arrive.
Sure. If like the patients coming if they arrive like the day before the medical checkup, for example, like do you also provide like the like pickup from the hotel to the hospitals?
We do offer one way. If let's say they're coming for screening or any outpatient clinic, so we provide one way airport transfer. Yeah.
Oh, okay, sure. So there's no airport pickup on Sunday, right? Okay, got it.
We don't provide
Mm.
during Sundays.
Do you have any like recommendations for like apartment nearby the hotels?
Yes, in fact, opposite Sunway Medical Centre, we have this apartment called Sunway Geo Sense or Geo Avenue. Can't recall the name, but Sunway Geo something. So there is quite a number of apartments, but those are individual units. So you just can do it via Airbnb. I think people list it on booking.com as well. So you have a choice of 2 rooms, 3 rooms, 4 rooms, etc.
Okay. Okay, thank you. And sorry,
Sure.
go back to the airport transfer. If the patients like get the airport transfer like the day before,
Yep.
and like for example, like they coming on Friday, and then like
Mm,
they arrange like airport pickup from the airport to the hotels, and for the
mm.
next day when they want to do the medical checkup, is it possible to arrange like free pickup from the hotels to the hospital, or it's
Okay.
only for yeah.
Yep. I see quite a few questions on the airport transfer. Let me maybe just kind of clarify
Yeah, sure.
itself, right? So at the moment, we actually have our Sunway Medical Centre van. So it's a fleet of vans with our Sunway Medical Centre logo. We provide complimentary airport transfer. So either it's pick up or we send off, right? So it's from the airport to Sunway Medical Centre. Uh, of course, if you stay in any hotel within Sunway City, because just now in my first slide, I showed you there's a few hotels within Sunway City. We can drop you there as well, right? So it's either we pick you up or we send you off. So
Oh,
we don't actually drop you at a hotel in just airport pickup, right? From airport to hotel, to Sunway Medical Centre. Of course, if the hotel is actually within the Sunway City, our drivers will drop you there as well. Hope that
Sure.
clarifies. Yep.
Yeah, I think we got all the questions answered. Is there anyone want to ask a questions, please? Oh, yeah.
Yes,
Do you
cash is accepted. No worries, Andy. I'm seeing the questions as well. Cash is accepted. Of course, bank transfer as well. Yes, all cards, debit card, credit cards are available as well. Shandy, just question. The majority of the audience are from Indonesia or
yeah, majority now is from Indonesia, but we have all over the world joining us right now, as
okay,
it's a little bit early for them. Yeah.
okay. Yep, thanks, Martini. I see your message. You send your patients this Friday. We happily welcome you.
Sure.
Any
I
more,
think
Shandy and the team?
yeah, I think if there's no other questions, we can wrap up today's sessions.
Okay,
So yeah, thank you so much for Mr. Lim and Dr. Sojin Kim for your insightful informations, and hopefully we can continue like our partnership, and we can do it like this kind of sessions later on.
great, sure. We're happy to be here today as well, and all the insightful questions as well. Thank you,
Sure.
everyone.
So thank you everyone. Thank you everyone for joining. Have a great day.